Okay, got it. Good evening, participants. Thank you for joining Shield Connect. Today we have a speaker from Bhubaneswar, Dr. Swapnita Hota, and ma'am is going to take a topic, myths and facts on PCOS. So before we start with the session, let me give a quick introduction of our page Shield Connect. So let me share my screen. So this is our page Shield Connect. Recently, we have got total 5 awards in our women health section, and there are various sections available in this platform. So first section is the blog section, where you can find all the latest blogs written by our eminent speakers and doctors who are connected with Shield Connect. Then we have a webinar section where we have two sections, upcoming webinars and past webinars. So if you click on upcoming webinars, so you can see all the details of the webinars that are going to be conducted. So if you click on today's webinar, like if you click on today's webinar on see more, so you just have to register or join here with your email ID. And you can see our webinar on this window, as well as it is also going live on our YouTube page. And dear delegates and participants, you can post your queries in this comment section. So at the end of the webinar session, we can have a Q&A with our speaker for the day. And this is the past webinars, where you can find all the webinars that we have conducted in the past with different doctors from various regions. Then this is the awareness pages. So you can see various awareness pages are available there. For example, PCOS awareness page. If you check PCOS awareness page, you will find all the videos regarding PCOS from different doctors in different languages like Tamil, Hindi, Malayalam, English. Then we have our leader section page, where you can find all the profiles of our doctors who are connected with Shield Connect. You can go through their profiles also. So for today's session also, you can go to profile of our madam. And there is a special day pages like Hypertension Day, Mother's Day. So if you click on any of the day page, you will get info regarding that day, like a Hypertension Day. So you will get videos and blogs regarding to hypertension. So this is our page Shield Connect. And now let me give a quick introduction of our speaker, Dr. Swapnita Hota. Ma'am has done MBBS, DNB in obstetric and gynecology, and ma'am is a laparoscopic surgeon and consultant at Women Wellness Center in Bhubaneswar. So I welcome you, ma'am, on our platform for today's session, and I hand over the session to you, ma'am. Thank you, ma'am.
Thank you. It was a very warm welcome. I'm not able to slide my screen through. I'm not able to slide my screens through. It is not moving. Slide is not moving.
You can please double click on the screen, ma'am.
Double click, yes, ma'am.
Yes. Okay. Thank you so much. So today, as said by Dr. Nishant, it is my topic will be myths and facts on PCOS. All through this, you would have many discussions on what is PCOS and all that. But this is a very general and normal topic for non-gynecics also. Many myths are there, and I want to clear that. Okay, so I will see how it goes and how I am able to tackle your questions after that. So as we all know that PCOS is, this is a endocrine disorder, basically complex endocrine disorder, and it is associated with menstrual irregularities, hyperandrogenism, infertility in the early life, and later part of the life. It can bring to diabetes mellitus, metabolic syndrome, cardiovascular diseases, endometrial hyperplasia, carcinoma, central obesity and complications associated with it, obstructive sleep apnea. Then also it will make a big psychological impact on the patient also. So we need to diagnose it early. So it is very crucial to diagnose PCOS, and believe me, it's not a small thing to diagnose PCOS. It is imperative not only to recognize it, but to delay it or arrest the metabolic sequel. That is more important. And screening test for the expected complications and timely management for the complications. So what should physicians should know about that? That this increased risk of PCOS, there is infertility, bleeding, irregular bleeding, endometrial carcinoma, hyperplasia, and related to that, obesity, obstructed sleep apnea, type 2, this all I'll deal with it, cardiovascular diseases. We should also take a note that it is genetically can be inherited also, but not clear. Nothing is clear till now, but still speculations are there that it is genetically related, because we have seen if daughters, sisters, they are at a higher risk of getting this PCOS, and she may require a long-term medication and healthcare access. So going to the history, it is originally it was described by Steen and Leventhal, okay, in 1935. So at that time, what we knew was it is a menstrual disorder, oligomenorrhea, amenorrhea, hirsutism, and polycystic morphology came later. It was not in that. We just knew that oligomenorrhea and hyperandrogenism features were the only thing which were discovered. So later part, when they did the bilateral wedge resection of the enlarged ovaries, accidentally they found in the open surgery, they found that ovary is enlarged. So after they took a wedge resection, they saw there are multiple cyst-like thing in the ear. So they termed the name as PCOS. Okay, and what was the progress in this 30 years is, now we know it is not just related to the menstrual disturbances and hyperandrogenism, but also features of insulin resistance is there. So there is a higher risk of going into diabetes, metabolic syndrome, and GDM also in the pregnant women. And so our current status research indicated that PCOS associated with a unique disorder of insulin action, as well as defects in the insulin secretions. And together, these abnormalities cause glucose intolerance. So going to the epidemiology, we have seen of late all these years, there is increasing trend of this PCOS. Globally, before we were not only talking about it, was not a very often talked subject about, but now of late these years, every second or the third patient coming to your OPD is a PCOS. We see in the community so many surge of this PCOS patients. So maybe because of the lifestyle or the genetic inheritance or the changes in the environment, we don't know. Nothing is foolproof. So it is one of the most common endocrine disorders, and it is a complex endocrine disorder affecting the women of the reproductive age. Like in thyroid, we know thyroid hormone, we know that hyperthyroidism or say hypothyroidism, we know that it is the thyroid as a hormone responsible. But here many hormones and many interplay of that hormones are responsible for this complex. So that's why it is a syndrome. It is not just a pinpoint thing. It is then, so the prevalence of PCOS that has increased globally also from 2.2 to 26% globally, depending on the age groups. This is the recent WHO 2020. So this is also the most common anovulatory infertility that accounts for 70 to 80% of the PCOS patients. And Indian prevalence, what I got from the National Health Portal 2021 is 22.5%, and one of the highest, take it a note, one of the highest in the world. So every fifth patient is a PCOS patient. So there is 22 coming to PCOD in India, it is 22% prevalence, and 117 million patients and still rising. One in every fifth woman is a PCOS patient. Complications, as I discussed earlier, also infertility, primary infertility noted in 50% and secondary infertility in 25%. So that is the huge burden. So obstetrics 3 times higher risk of gestational diabetes mellitus, preterm deliveries, complications as like gestational hypertension and preeclamptic disorders, twofold increase in the IUGR, preterm labor complications, and all those. So cardiovascular risk also increases, metabolic syndrome, I will take it later, oncologic, again, endometrial hyperplasia, because of the unopposed estrogen activity, there is higher chances of the endometrial cancer. So it is very important to prevent this and unopposed estrogen activity. And psychosocial, psychological, menstrual irregularities. I have kept menstrual irregularities in this section because in India, women always relate their menstrual health with everything, and they get very mentally disturbed. If their menses are not correct, they get very mentally disturbed. And it is first, we have to deal with this psychological counseling, then the treatment part comes. So that's why I've kept it in psychological. So there is fourfold greater odds of depressive symptoms, higher prevalence of anxiety disorders, and of course, reduced quality of life. So as I told, there is no universally accepted definition of PCOS because it is a complex thing. It is not, nothing is pinpoint. So it is a heterogeneous, this I have taken from the Williams Gynec. So it is a heterogeneous multisystemic endocrinopathy in the repetitive age group. It is a modifiable disease, not a treatable disease. It is a modifiable. It's like hypertension is modifiable, diabetes is modifiable by our lifestyle management, diet, exercise, and certain drugs, help of certain drugs. So these are the different criterias to label PCOS. So first was the NIH criteria. So there were, it was in first in 2006, I guess. Yeah, 2006. It is the following criteria were clinical or biochemical signs of hyperandrogenism and menstrual dysfunction. The ESHRE and ARSM then criteria, they bought that no, three criteria after there. There has to be a clinical or biochemical signs of hyperandrogenism. There has to be a criteria of oligo menstrual disturbances, and with that, you have to have a ultrasound diagnosis of polycystic ovaries. So among these three, any two is okay. So if two criteria are also there, we label this patient as PCOS. So now Androgen Access Society 2006, they told no, all the three criteria are important, like clinical or biochemical signs of hyperandrogenism, ovarian dysfunction, and or polycystic ovaries. All the criteria they have taken into considerations. So all the society names are down. So now NIH, this is the recent criteria. It has come on 2012. So in this, they have divided into 4 phenotypes because according to this, all the patients are not fitting into all the criteria. So the criteria the patient fits in, according to that only we will give the management. Okay, so there are certain patients who have hyperandrogenism, oligo or anovulation, and PCO morphology. I have written it. I have not written PCOD. I have written PCOM. That is PCO morphology. All the three they will have, or certain subjects will have HA plus OA, or certain will third group will have HA plus PCOM, then a certain group will have OA plus PCOM. According to this, we give the management. So this is very, for the clinician benefit, this phenotypes has been covered. So this is the NIH 2012 criteria, recent criteria. So for PCOM, USG features, it should be done by TVS. It is very specific. This should be done by TVS. We will not do the PCO criteria till 20 years of age. They say after 8 years, till 8 years of menarche, we don't need to have this ultrasound as a feature. So it should be done by TVS. Follicle number FNPO, that is follicle number per ovary, is raised to 20. Before it was 10, if you remember, in the Rotterdam criteria, and ovarian volume should be more than 10 ml, and or okay, anything, and or it is follicle number should be more than 20, or ovarian volume more than 10, anything will okay, is okay. So hyperandrogenism feature, this is for our understanding: hirsutism, acne, androgenic alopecia. Now there is another term known as virilization. This is the increase in the muscle mass, like in the male we see voice deepening, clitoromegaly. So these are the extreme features of hyperandrogenism, and so much extreme features, if they are there, we should not only think about PCOS, we should be thinking about other androgen excess diseases or medicines. Okay. So now coming to my topic, myths and facts. So myth 1, all women with PCOS have ovarian cyst. So based on its name, I told in the history why this name was termed as PCOS, PCO, polycystic ovarian, like why it was called. So as the name suggests, PCO refers to cyst, but this is a false notion. Actually, the cyst, this tiny follicles are there, which are arrested in different phases of their ovulation process. They have not ovulated due to this anovulation. Every cycle, a egg, it is arrested in some or the other part of their life cycle. So they have the appearance of that strand of pearls. But without this also, as I told, that 4 categories, without this also PCOS features can be there. So not all women diagnosed with PCOS have follicles in their ovaries. Myth 2, women diagnosed with PCOS can't have children. Like fertility is connected to that, but it is not so. Yes, incidence of infertility is higher, 25 to 50%, but it doesn't mean that she is infertile. So they can also conceive with the help of fertility treatments, or otherwise only lifestyle management also improves their chances of conceiving. Like if they reduce 5% of their weight also, naturally they have the year to conceive. So of course, complications will be early miscarriage, GDM, these are all high in PCOS, GDM, preeclampsia, preterm labor and all that. So an irregular menstrual cycle means you have PCOS. It is not so, because only in PCOS, yes, in PCOS due to anovulation and chronic estrogen, there is menstrual disturbances. But there are so many other reasons. Typical cycle range between 21 to 35 days, and other factors are stress, thyroid disorders, endocrine conditions are there, hyperthyroidism, prolactin levels if they are high, fibroid, extreme dieting, severe anemia, and also this athlete and all who work out more, for them also cycles will be irregular. So additional test, you have to visit your doctor if you have irregular cycles, and additional test and exams will identify the cause. So another myth is women with PCOS, they have a nice bahana that I have got PCOS, so that's why I'm not losing weight. It is not so. Yes, in PCOS it is harder, because they have told there is a correlation between the insulin resistance and the obesity, that is the central obesity or the android obesity they tell. But by maintaining a healthy diet and a lifestyle, with the conjunction with a dietitian, endocrinologist, and weight loss goals are also there. So to say, they have to set the target goals, and then it will be by this help, losing weight cannot be so difficult. So this picture I have shown the correlation between the increased androgen secretion, insulin resistance, and the weight gain. It is a vicious cycle. So for this weight gain, or this causes weight gain, it is a vicious cycle. So all women with PCOS experiences unwanted hair growth. It is not so. Hirsutism is the excessive growth, as we all know. It is a male pattern hair that occurs in the face, back, unwanted hairs, what we say. So hirsutism is due to hyperandrogenemia. If the features of hyperandrogenemia is there, then only they will have the symptoms. But without that also, it can be there. And other diseases are also there, androgen excess diseases, which will cause this, and ethnicity and all also are related to it. So you need an ultrasound to be diagnosed with PCOS. So in this fact, you don't need to have an ultrasound if you have criteria 1 and 2, that is a clinical and biochemical. I told you, without the ultrasound criteria, having that cyst and all also, PCOS can be there if you have clinical features or the biochemical features. So, and this normal ovarian morphology of an adolescent female, like till 20 years, adolescent female, will be PCOS morphology. So we will be wrongly diagnosing it only on the basis of this ultrasound diagnosis of PCOS. We should not do it. We should only write PCO morphology. We should not give the diagnosis like in the radiological reporting, ultrasound reporting. Many a times you will have seen that PCOS. There's write PCOS. It is you should not write PCOS. You should be writing PCO morphology. That diagnosis is then subjected to other evaluations, so that that clinician will make a diagnosis of it. So myth 7, if you're not looking to get pregnant, you don't have to worry about PCOS. It is not so, because not only pregnancy and menstrual irregularities, but the long-term sequelae are also, we are protecting from inhibiting the progression of the disease. So it just doesn't affect the women had fertility. It has long-term wellness for the rest of her life. So it has been linked to type 2 diabetes and metabolic syndrome. So so getting diagnosed and treated is critical for the women's health features. We also prevent her from this unopposed estrogen activity like this endometrial cancers, hyperplasia and all also. So metabolic syndrome is diabetes, hypertension, obesity, dyslipidemia. So this is the criteria for metabolic syndrome. Risk factor is the abdominal obesity more than 88, triglycerides more than 150, HDL is less than 50. These are the good cholesterol, and blood pressure more than 130. Fasting and 2-hour glucose from oral glucose tolerance test, it is 110 to 126 mg per dl, or 2-hour, it will be more than 140 to 199. So these are the risk factors for metabolic syndrome. So myth 8, everyone with PCOS is obese or overweight. So this is also a misconception, because nowadays lean PCOS, we are seeing a surge in the lean PCOS. They will be perfectly, their BMI and all standards will be perfectly fine, waist hip ratio and all that will be perfectly fine, but they will have severe menstrual disturbances, hyperandrogenic features and all that. So thin women might commonly be overlooked, and as obese women with irregular periods might be inaccurately diagnosed with PCOS. So myth 9, insulin resistance in PCOS cause weight gain. So that I told already, that it doesn't cause insulin, insulin resistance, it doesn't cause weight gain, but it is a vicious cycle. And lean PCOS are also there. They have severe insulin resistance, which is unexplained. So why they will get? So that's why obesity, if we connect with the hyperinsulinemia, then that is only a theoretical thing. So myth 10, every woman with PCOS should go on the birth control pill. It is not like that. It is common way to treat the menstrual irregularities, but it depends on what category you fit into. So if there are other lifestyle management features also, healthy balanced diet, and I came across anti-inflammatory dieting, keto diet and all that, nutrition therapies and all. So these are the daily consumption. You should have fruit, vegetables, whole grain, olive oil, nuts, legumes, spices. Then regular this I have made a food pyramid to show that which you should be regularly taking and what should be avoided. So there are all keto diet, zero carb diet, and all that. There are different apps also for this. Etiopathogenesis of PCOS coming into this. So this is genetics or lifestyle changes is causing hormonal changes exacerbated by obesity, causing a low-grade inflammation. So this theory has come up new. Low-grade inflammation it is causing. So that causes hyperandrogenism, insulin resistance, and all these features. Clinical hirsutism, acne, reproductive features, menstrual disturbances, metabolic syndrome, psychosocial issues, body image, self-esteem, depression, anxiety, and this is a very important part to deal with. First, we have to deal with psychosocial issues. Then we will go into treatment part. So this is very important thing because they go into suicidal tendencies also. So spectrum of PCOS from childhood to post-menopause. PCOS predisposing factors are genetic factors. In utero programming only occurs in the mother's womb only. So in childhood, prepubertal years, there is increased AMH levels, puberty, premature adenarchy, hyperandrogenism, increased AMH levels, ovarian volume, hyperinsulinemia. So reproductive age, they will have subfertility, infertility, increased AMH, antral follicle count, and glucose intolerance, insulin resistance. Postmenopausal, they will have increased prevalence of this metabolic syndrome and cardiovascular risk, endometrial cancers, the increased risk of endometrial cancer, and so on. So these are the phenotypes which I already discussed with you, NIH 2006 criteria. So I'll not be going into details. So PCOS in the adolescence, it is diagnosed in the adolescence, but the diagnosis is very difficult. In utero, the exposure to the fetal testosterone, hyperglycemia, hyperinsulinemia determine the PCOS phenotype. So GDM and all patients also, they can consider that their baby has a future risk of going into PCOS. So we need more studies on that, but this is also, we can correlate. Family history of PCOS, overweight or low birth weight, exposure to androgens during the gestation, precocious puberty, obesity, insulin resistance. These are all the in the PCO in adolescence, how we diagnose. So PCO in adolescence diagnosis requires a stricter criteria. Why? Because we have already cut this ultrasound criteria, and uh, 1-2 years it is normal because the HPO axis has not got matured. So after 2 years it should get matured. So now in coming the postmenopausal women persist with hyperandrogenism even after menopausal transition. So they are a higher risk of into this metabolic diseases, MI, cardiovascular accidents, and all that. And and they still have manifestations of this syndrome. So this genetics, lifestyle, this epidemiological link, PCOS increases the risk of GDM, as I already discussed, present in insulin resistance is present in 65 to 80% of the PCOS cases. 60% of the GDM patient develop type 2 diabetes, and PCOD increases the risk of type 2 diabetes by 4-fold. So pathophysiology of PCOS, considerable debate on what actually, but after so many discussions also still we are blind that what actually caused this PCOS. So key biochemical features present in the vast majority of women are insulin resistance and chronic low-grade inflammation. So development of insulin resistance, what it can cause, why it is important. It is insulin is primarily responsible for controlling the LH levels, which are very low in this, and control the it is high in this, tenfold high in this. So, and it controls the androgen levels, which are also high. It insulin mediates androgen production in the theca cells. So this insulin resistance coexists in PCOS, and it inositol deficiency drives PCOD. I'll come what is the relation between inositol and the insulin resistance. I'll come into that physiology. This insulin resistance seems to be driven by deficiency of myoinositol and D-chiroinositol. So insulin signaling is damaged in PCOD. Oxidative stress and all leads to hormonal and metabolic disturbances. Because of the dysfunctioning, disrupts the LH and FSH pathways and causes hyperandrogenism. So evolution of PCOS, environmental factors, genetic factors cause inositol deficiency, deranged insulin signaling. So we are all these years telling insulin resistance, but why this insulin resistance is occurring? So this is a theory that inositol deficiency is causing deranged insulin signaling, and then the cycle continues: pituitary dysfunction, enhanced ovarian androgen production, and development of insulin resistance. So clinical features are, as we all discussed, clinical hyperinsulinemia. How we will diagnose it as hyperinsulinemia? So ratio of glucose to fasting insulin is important. The ratio of less than 7 is suggestive, and a fasting serum insulin level of more than 15 and serum insulin level post glucose more than 25 represents hyperinsulinemic status. So our first line of management should be always improvement in the lifestyle, counseling, in obese patient, weight loss, change in the diet, and physical activity. In lean PCOS also, we have to give them a nutrition plan with the nutritionist, so that their caloric deficiency will not be also there, and this disease progression will be also checked. So, so weight loss decreases the serum insulin and reduces the risk of glucose intolerance and type 2 diabetics. So then comes the pharmacological interventions, which will improve the insulin resistance. So now what we have with us in the current scenario, these are the to tackle with this hormonal imbalance, metabolic imbalance, all these things, we have this much availability with us. That is the insulin sensitizers, metformin, pioglitazone. We don't give pioglitazone and all because metformin that is questionable in the pregnancy. Metformin we can continue also in the pregnancy. Anti-androgens, if we are giving OC pills, that should be containing this anti-androgens. They like cyproterone acetate, spironolactone. So OCPs, oral contraceptives, having this anti-androgenic progesterones. Then ovulation inducers, that is the infertility, people going for infertility, we can give them clomiphene citrate, letrozole. Nowadays letrozole is more preferred than clomiphene citrate. Cosmetic for this excessive hair growth and all, depilation, epilation with the lasers and all therapy. And surgery is reserved for unresponsive patients. So it does benefit LOD, that is the laparoscopic ovarian drilling, and bariatric surgery for the excessive obesity, called morbid obesity patients and all. So, so managing this menstrual disturbances, a low dose oral contraceptives is recommended, preferably anti-androgenic, cyproterone acetate, drospirenone. So these are some examples. Yasmin, Dan 35, Crimson 35, bucket of choice is there. Inositol in PCOS. So what is the role of this inositol in PCOS? So that we will go now. So inositol is the insulin signaling molecule. So as you can see this in the This is the cell membrane. This is the cell membrane, and the insulin receptors resides in the cell membrane. When it's beta subunit, there is a alpha subunit and there is a beta subunit. So alpha subunit is above the cell membrane, and within the cell membrane is the beta subunit. So beta subunit is phosphorylated by insulin and insulin receptor substance. So in this, the P13K, it docks to the, when it docks to the insulin receptor substance, it leads to phosphorylation of this phosphorylation of the phosphatidylinositol and eventuating the insulin action. So then only the insulin comes inside the cell and its action occurs. So myo-inositol, what it does, it increases the insulin sensitivity by making more phosphatidylinositol available. Okay. So both MI and DCI levels are low in this PCOS patient. They have done a study. So in this, they have seen that compared with the normal subject, in the PCOS subject, it is low. So myo-inositol and DCI in PCOS, there is 40:1 ratio after. So they have seen that it normalizes the insulin signaling and the glucose metabolism. Weight loss starts, insulin level becomes normal, LH levels become normal, menses become normal, and androgen hyperandrogenemia is also comes down, and fertility is restored. So this is the Cochrane study also, which shows that in the infertility patient they have studied. Live birth outcome is more in the PCOS than the, giving this myo-inositol and chiro-inositol than the control. We can say that PCOS is a multifaceted condition, and so that's why multidisciplinary approach. We need endocrinologists, we need nutritionists, we need wellness therapists, and we need also psychiatrists, and of course gynecologists, not to forget. A holistic care to increase the success of fertility treatments, lifestyle modification, diet, exercise, behavioral therapy. Oral agents such as letrozole is preferred over clome in the first line treatment. Then go for this gonadotrophin injections and all. IVF and ICSI are only indicated when previous interventions have failed, or there is other factors like tubal occlusions or male factors, which are the for the indications for this. So that's all. Thank you so much. I will very much appreciate your questions.
Thank you, ma'am, for giving the information regarding myths and facts of PCOS. So till then, if I check the questions in the comment section, can I play video, ma'am, of our Shield Connect products?
Yes, of course.
Thank you, ma'am.
Can you please stop the sharing? So then, Nishan, you want to play the video, na?
Yes, I can play it.
Acha, take. Ma'am, screen is going on, na? Okay, take.
thank you, ma'am, for making us play this video. And now let me share some questions we received. So, ma'am, first question: does yoga helps in curing PCOS in the woman?
Of course, but there should be a yoga instructor.
Okay. So,
Of
like,
course,
there
it
are some
reduces
different poses.
the theory behind that is it reduces the oxidative stress. So this
Mhm.
local inflammation therapy
Mhm.
it gives.
Yeah.
Anti-inflammatory, I'm sorry, anti-inflammatory. So I mentioned about this anti-inflammatory diet also. This
Right.
also
Yeah.
a new thing I have seen, but yes, there it is there, anti-inflammatory diet.
Then the second question is how much sleep health is important for PCOS women?
In this our urban population, what we have seen, there is a rise in the PCOS cases than
Hmm.
the rural part. The
Yes.
main reason may be the stress, inadequate and unhealthy lifestyle, erratic our sleeping and waking up disturbances, and also that
Mhm.
rhythm is only disturbed. So that also can lead to oxidative radicals and all in the body, which is again it is a very much logical thing to correlate with that.
So, ma'am, also you have given importance of psychological treatment,
Yes,
counseling. So,
yes, it is a very important
how
part.
do you counsel the adolescent PCOS patient who come with the stress regarding the cosmetic issues, like they find more pimples or hair on their face?
It
So,
is
how
of
do
course
you
very difficult.
handle such cases?
It is of course very difficult to, and believe me, the more important is the psychological aspect. They are very much conscious about their body image and all that facial issues, and than their disease. They are
Yes,
not interested to hear anything about that. They are
yes,
only interested about their what is
outer
body
look.
image. So yes, we have to give time to them and counsel them regarding the disease process and all, and the importance of weight loss and the healthy lifestyle. If they are lean PCOS, also we have to give them a healthy lifestyle, like the nutrition, a balanced nutrition chart we have to provide them, and also what they can do their healthy life to manage their healthy lifestyle, what they can do, and of course the treatment part also is there.
Okay.
It is
Then
very
the
difficult to deal with them. Sometimes they get psyched out of it.
one more myth regarding thing, like Cushing syndrome is similar to PCOS. So
No,
how can you differentiate?
yes, that is a very valid question. Actually, the androgen excess, what I told, the PCOS, they are hirsutes, but they are not virilized. Like virilization, what I told is the excess and very much androgen excess part. Like there will be increased muscle mass will be there, and all that deepening of voice and all that features. So in that we have to think about other things than PCOS, which causes androgen excess, and Cushing syndrome is one among them. And there the your what we see this testosterone and these levels will be increased more than 200 picogram per liter. So less than that, we will see in the PCOS. But more than that, we will think of this other features. So virilization is something we will, it is a clinical sense also. Virilization features are more related to the Cushing syndrome and all. For that, we need an endocrinologist, conjunction with the endocrinologist to treat that disease. But that's why I told it is a very challenging thing to diagnose a case of PCOS. It is not an easy job.
Then, ma'am, one more question is that nowadays I heard about hidden PCOS syndrome. So, like, what are the hidden symptoms of?
Hidden PCOS may
Yes.
be referring to this lean PCOS.
Okay.
It is lean PCOS because all this through we have learned that PCOS means what comes in your mind first, a
Obvious.
fatty female, a
Yeah.
fatty with a lot of acne, comedones and all that, with this blackening in the neck and all, which is acanthosis features. So like this a picture comes, but nowadays we have seen as clinician, we every day we see more of this lean PCOS cases. So how to explain that when we are telling, we have correlated also in my one of the slide also, I have correlated obesity with this insulin resistance, but this is not going with that. So we have to think something beyond, we have to do more researches. This lean PCOS is something new to this. So that is the hidden PCOS. And in that also insulin resistance is there, hyperinsulinemia is there, and hyperandrogenism features are also there. So that is the thing.
Oh, I cannot see more questions, but thank you for all the answers for these questions which were asked. And we also thank you for joining us today, ma'am, and giving this important information regarding PCOS today. And we would like to have more sessions with you in future on our platform, ma'am.
Thank you so much.
Thank you so much, ma'am. And I also thanks delegates for joining today's session. Okay, ma'am. Thank you.